Once it goes in, 3, 2, 1.
Hey guys, welcome back to the Foam Frat podcast. This week we're talking about gas laws. Sam interviewed Mike Brown. He's one of the Foam Frat team members. He does a talk. He's actually speaking at EMS World on diving emergencies as well. You don't want to miss it. But what I really liked about this episode is the conversational manner that gas laws were discussed. It wasn't like you were just reciting the definition from an FPC, CFR, and prep book. It was like real life examples of Henry's Law and Boyle's Law. And I found it super entertaining. And I love Mike's comparison with diving. And he really does a great job with that talk. And I'm looking forward to seeing it at EMS World. So nice job, man. I thought that it all came together really well. Was there any points or any highs of the interview that you liked particularly?
I like when we get into the basic physiology too, because the pathophysiology is really fun when it comes to treatments, obviously. But I'm a huge fan of like understanding really deep down into the basics why the normal stuff happens. And Boyle's Law and Henry's Law, the two that we focused on. There's more in the blog, but I wanted to focus on like the heavy hitter clinical ones. But those two apply so much to just the regular way that we breathe. And then if you can understand those, the arrangements become really simple. So yeah, like you said, there's the normal gas law and here's the rule. And, here's 5 bullet points on how you can, here's the variables and like, here's 5 bullet points on how it applies. But a story helps a little bit. And then understanding how it applies to basic physiology, because yeah, like I said, once you understand where those apply in basic, then any treatment that you do that relates to them becomes super, super simple. So yeah, I had a bunch of fun talking to Mike about this, and that was a while ago. Tyler and I, if you saw me trying to hold it together, we were just talking. It's like 6:00 at night right now. So I recorded this podcast with Mike like 12 hours ago, no, 14 hours ago. And we were just saying how difficult it is for us to record after this. So I'm actually surprised that I'm holding it together right now. I was about to burst out laughing when you first started. This is like our third time around.
You're forming sentences and they sound good. Yeah. I watched it when you sent it to me. So typically what we do is one of us will interview somebody, or if we're not talking to each other, and then we send it to the other person to watch. And then we do a little intro. And, I don't know. I think I got that idea really from Dan Rosiniak and Howard Greller. I like that format where they would interview somebody and then it'd be a little bit of dialogue. And I was watching this at the gym, and I'm like, man, it's super cool because the stories and like the real life application and just the discussion of things that at one point seemed like so dry to me helps concrete it. And I think that if you're studying for the FPC or the CFR and you can remember those rules or whatever, remember the sayings, but the Charles centigrade and Henry's Heineken, and I don't know, those things all seem super dumb. Like an actual functioning understanding of those gas laws is super helpful when it comes to oxygenation, CO2 clearance, why the aircraft shows that you have more oxygen in the late afternoon when you look at the pressure on the tank, as opposed to early in the morning. As that pressure increases, as the temperature increases, the pressure increases. And so knowing those things and putting real life application to it, I think is super important. And I think you guys are going to love this podcast.
Well, we were going to talk about gas laws today, and I thought Mike would be the perfect person to have on because I know that he's got a personal experience running into one of these gas laws. And so before we get into that, and we have Mike tell us what gas law he had a run-in with here, Mike, welcome back. And why don't you give us a shameless plug for, I was going to say the new podcast, but it's not that new anymore.
No, we're not the newest kid on the block anymore. It's pretty exciting, and it's really starting to gain some traction. Thanks for having me, Sam. I really appreciate it. Not sure how I feel about being your go-to guy when you got to talk gas, but I do appreciate you having me here. So the other podcast that Sam is talking about is the RSI podcast, or Rapid Sequence Interrogation, that Jared Patterson and I host. And I tell you what, it's been kind of a labor of love. I mean, obviously anybody that does a podcast knows there's some work that goes into it, but it's just so much fun to see the questions that come through, the interaction that we get to have with different guests, and having different people on. Our last guest, or most recent, was Tom Bouthillet, and I tell you what, he's coming back without a doubt. Got some great questions specific for him, but really kind of got outside of, his wheelhouse is kind of the EKGs. Obviously that's where a lot of his background is at, but he's just got so much depth in so many other areas. He's coming back for sure. And it was a great podcast, and we really, really had fun recording it and got into some different subjects. So, keep the questions coming. If you're listening and you have some questions that you want Jared or I to answer for you, rsipodcast@foamfrat.com. You can email us there, or you can find us on the website. You can find us on iTunes, wherever you get your podcast from, RSI Podcast. But we'd love to hear from you, and you can ask us anything. It doesn't have to be medically related. Sometimes when it's not medically related, that's when we get better responses out of Jared. I never know what he's going to say.
Rather unscripted.
Oh yeah. Well, awesome, no, it's totally unscripted. We just have fun with it. The format is kind of like a rapid fire. We try to answer stuff 5 minutes or less, trying to stay within that the attention span of most people that are going to listen to it, including us.
Unlike most of my blogs that I write. So you read this blog through. We're going to be releasing it, well, I guess at the same time as the podcast probably. So this will probably come out on Friday. But so I started off with like ideal gas, and then I had boils. But then you were like, man, you got to add Henry's law in there, because you can't really talk about Henry's and boils kind of separately. So tell us, what was your experience? Well, I guess we'll start off with the Henry's law. And so what is that, and what happened?
Yeah, so Henry's law, simply stated, says that there's a direct proportional relationship between the pressure of a gas over the liquid and the amount of gas that you can get into solution within the liquid. And in this case, it's the pressure of the gas over the liquid is what's in our lungs, and the liquid is blood. Right. So it has limitless clinical applications when we talk about moving gases in and out of solution, getting oxygen in, CO2 out, things like that. But I ran head on into Henry's law a couple of years into my my diving experience. So for those of you that don't know, I'm an avid scuba diver. Enjoy checking out shipwrecks in the Great Lakes. Done some technical stuff. So like down to, I think like 260, 270 is my deepest wreck. So doing some things on the tech side. We mix in different gases, but not going to get into all the diving side of it. But I went down and was checking out this shipwreck, really, really sweet shipwreck, completely intact, sitting on the bottom of Lake Huron. And that's what's so cool about the Great Lakes. It's freshwater, it's cold, so it preserves everything. And these shipwrecks are just like time capsules. So it's pretty sweet to go down there and check these things out. Like, you know, it's a sailing vessel, still had the masts intact. There's rigging hanging from the mast. So it's pretty sweet. Yeah. Checking this out, having a great time. And then I'm starting to ascend up. So I'm doing my my set stops at different depths and changing to different gases so that I can off gas nitrogen, and in this case also helium, because I was breathing a gas mixture that contained helium, so that I'd have less nitrogen. Reason for that is, just real quick, nitrogen is narcotic at depth, or it causes hallucinations, which isn't something that you want to experience when you're a couple hundred feet underwater.
You start seeing pirates on the mast or something, or what?
Right. Yeah. Oh my God. Did you see that? That ship's coming right for us. So we put some helium in that to offset the nitrogen. So as we're ascending, have to get all that back out of solution. This is all over Henry's law at work. So get to my final safety stop. I was there just a little over 20 minutes at 20 feet. Total dive time was over an hour. Once you put in decompression stops and all that, you're actually decompressing much longer than you're checking out this really sweet shipwreck. So I get up to the top, my head just breaks the surface, and I start to feel this little ache in my elbow. I'm like, that's kind of weird. So just like acute coronary syndrome, DCS is no different. Decompression sickness. First sign or symptom is denial. So I started thinking about, oh my God, okay, this is anything but DCS. I'm not bent. So that's like the diver slang term for getting decompression sickness. I got bent. So I get out and I'm like, just probably overexerted a little bit. This gear's all heavy. I'm moving tanks around and just going through my head. Okay, this is anything but DCS, anything but DCS. I'm not bent. No way. And pain just keeps getting worse and worse. I mean, like really, really bad pain, and starting to get some numbness and tingling down my arm. I'm like, oh, shoot. So I think what I thought it was to begin with is probably what I'm dealing with. So, the boat captain put me on some high flow oxygen, because what you're trying to do there is get as much oxygen in the lungs as possible to create a gradient to get nitrogen and helium out, because that's what I'm trying to get rid of, potentially have a bubble that's blocking some circulation. They have to wait for the other divers to finish their dive. It's not like you just cut the line and leave. So waited about 45 minutes for the other divers to finish their dive. And then they took me to the boat ramp, got out, about a 45-minute car ride to, at that time it was the Alpena Regional Medical Center in Alpena, Michigan, and got a 4.5-hour chamber ride in their little tube of a chamber. It's this like glass tube. They slide you in there with a sippy cup and a urinal because you're not coming out.
What if you
I watched The Sum of All Fears twice. So they have,
what if you really had to use a bathroom in there? What if you
like a number two?
Yeah.
You just got to do it, man. You're there
in the tube.
Yeah.
Of course, that would be my first question. You had this traumatic.
Of course, yeah. What if you got to poop?
What if you had to take a crap in the tube?
So seriously, I that's interesting. I hope to never have to be in one again, but I don't know how that pressure would work out if it'd be. If you're trying to, there's pressure pushing in on everything, including where that's coming out of.
Yeah, transabdominal and the other pressure should maybe work out. So
right. Is this
interesting?
Perhaps a new record for getting to poop talk? How far into this are we?
So you're in this tube. You're in there for like 4 hours. And how many atmospheres do they put you under? And I guess I should ask, like, how many? Does it matter how deep you were diving? So you were 200 some feet underneath. Isn't it? How many is it? 33 feet per atmosphere or something like that. So how many atmospheres are you under?
Yeah, so you get 33 feet per atmosphere, but you always have to add 1 atmosphere to that, because you've got an atmosphere that you're just experiencing at the surface. So for every 33 feet, you add an atmosphere. So actually at 33 feet, you're 2 atmospheres.
Okay.
Because you have the 1 atmosphere that's always pushing down on the water, and then you have the other atmosphere that you added through the pressure of the water. So it's kind of a time dose relationship. So the deeper you are, the more you're going to on gas, but your tissues reach a point of equilibrium where they're just saturated. So they're not going to take on any more. But you're going to continue to rack up decompression debt, we call it, or time that you have to spend decompressing as you come through the water. So it's more of a depth and time relationship. But a lot of that doesn't necessarily affect the length of your chamber ride, because they're just trying to recompress those bubbles. And we'll talk about, we'll probably dig into the gas law that's working there, but they're trying to make those bubbles small again so that they can free the blockage potentially, and then get them moving so that they can get to the lungs and get off gas, because your body's going to get rid of this stuff. It doesn't want it. The concentration gradient, it's always, our body's always trying to find equilibrium.
Yeah, that always reminds me, because I was obviously, they call Henry's law the soda can law, but soda can, sure. You have like the gas, and then you have the liquid, and obviously the CO2, the carbon dioxide. Yet that air above the liquid is really pressurized, and so it reaches equilibrium with the fluid. But when you open a soda can, you can't see the bubbles coming out. So I like to think of like a beer bottle, I guess. So when you open a beer bottle, if you have clear glass, before you open it, you can't see those bubbles at all. It's totally suspended, and all that pressure has compressed those gas bubbles into tiny, tiny little. Obviously you can't see them, but then once you pop the cap on the beer, as they escape that fluid, they all get together, form larger bubbles, and that's why you can start to see those coming out of the liquid. But if you were to repressurize that bottle of beer, you wouldn't see those bubbles escaping anymore, right? So that's
Right.
kind of how I think about what you guys do with the hyperbaric chambers. And so, did you say how many atmospheres did they put you back under? So they kind of put the cap back on your beer bottle.
Yeah, they put the cap back on. They take you down to 3, usually around 60-ish feet, I think is what the Navy dive table is that they run. So it's 3 atmospheres of total depth. But yeah, I mean, what they're doing is trying to recompress those bubbles, like you said. I mean, a closed beer bottle or beer can is like think of the diver at depth that's saturated all their tissues. So as you said, kind of all of that gas, or in this case CO2, that they've compressed into that can or bottle is all in the solution. So Henry's law has caused that to come into solution. Now you pop the cap off, or you open the tab on the beer can, and now you've got 2 gas laws at work. It rarely does one of these gas laws work by itself. There's usually some sort of combination. Because Henry's, it's coming out of solution. Those bubbles are coming out, but they're coming out because they're increasing in size because you decrease the pressure. So then you step right into Boyle's law, and that's where Boyle's and Henry kind of chill out together. I mean, those 2 gas laws are very well intertwined. They're one with the other.
Yeah. So before we jump into Boyle's, because I've got a little experience about Boyle's law I'm going to tell you about. Now, I won't be able to top your story at all, but it still sucked. So before we jump into the Boyle's stuff, let's talk a little bit about how we can manipulate Henry's law besides hyperbaric, because obviously that's a treatment for decompression sickness and stuff. We can also create different kind of atmospheres and pressure gradients with gas, with even just oxygen. So when people think about, what is the main application of this law that you're going to use on a daily basis, it's really oxygen administration. And you can increase the partial pressure of that oxygen just by literally giving somebody oxygen, obviously, because you're increasing the partial pressure of that gas, how much gas is in, I guess, like kind of the atmosphere above their serum, their blood. And so that's one way. And so that's what causes that oxygen to want to diffuse, because it's going down its concentration gradient. You could think about that the other way too. And we need to blow CO2 off of somebody, and so we increase their minute ventilation. We're just giving them more fresh gas into their lungs so that CO2 wants to diffuse across, because it's the more fresh air you get in there, the more it wants to go across its concentration gradient. And so that's a really cool thing about that law, is if you understand the basic physiology of it, where it's like, yeah, that's essentially why gas goes in each direction, from the atmosphere in for oxygen, and from CO2, in the blood out to the atmosphere. And without those concentration gradients and things wanting to go in that direction, we would just cease to exist. Pretty much, we just all fly. So when we can manipulate those, either with increased minute volume for a patient that needs to get CO2 out, or we can manipulate it with just regular oxygen, or even if you want to turn yourself into more of a beer can, more of like CPAP or PEEP or BiPAP or whatever is going to increase the pressure of kind of that local atmosphere. Now, let me ask you this. Would you put a patient with a Benz? So first of all, I guess just 2 things I was thinking of. You don't fly them, right?
Yeah. So that's a great question. And that's a question that people routinely ask. So rotor wing transport is generally fairly safe because there's not as large of an altitude change. Mm-hmm. I had a great conversation with a DAN doctor, so Divers Alert Network. They specialize in care of ill and injured divers. And they said that if you have particularly like severe case of DCS where it's it's affecting their pulmonary, cardiovascular, or neuro system. It's the speed of transport and getting them to a recompression chamber outweighs the risk of the altitude change. Now, things are a little different if we're talking fixed wing, because then potentially we've got a greater change in pressure. So, they're generally at higher altitudes. So there's a delicate balance there, and it's something that we can entertain depending on the condition of the diver. Like my condition that day with just simple, it wasn't simple for me. It hurt like heck, but just that simple joint pain or skin symptoms, that's really not an indicator to fly somebody. But think about if that bubble has lodged in my cerebral circulation and I have stroke-like symptoms, or those bubbles can lodge in your coronary vasculature, mimicking a STEMI, or they just pick that day to have their STEMI. So don't always blame the dive. Just because somebody just got done diving doesn't mean it's the dive's fault.
And then, so my other question is, and by the way, so I guess I have a follow-up question for that. Do they try to fly at a lower altitude?
Yeah, generally they'll try to, as safe as possible, because the higher you go, the lower the pressure is. So then the bubble potentially gets larger.
So my other question was, is CPAP automatically indicated? Does it matter if you're putting a pressure into their lungs, or is this more so just a local thing that wherever this bubble is going to be, it's going to be, and it really doesn't matter if you put them on CPAP or not?
So it's not going to matter a whole lot, because what we're really looking for is systemic compression. So compressing the whole person. Because like in my case, I had a bubble that was blocking the microvasculature throughout my arm that was affecting its ability to move blood and get rid of byproducts. So that's what's causing my pain. I'm experiencing distal limb ischemia. So that's what's leading to that discomfort. So CPAP is not going to benefit me at all. Because we need systemic pressure to decrease bubble size and also help to move any other bubbles that may be trapped, or get them through the circulation in the smallest size possible. So CPAP really isn't going to do that. CPAP's only going to, I tell people, if we're trying to increase the amount of oxygen that we're delivering, and we're delivering it at 100% or pure oxygen, the only thing we can do to deliver more of it is deliver it at pressure. It's Henry's law at work. If we're already giving all the oxygen that we can, the only thing we can do to get more of it into solution is to increase the pressure of the gas above the solution. So you were right on with your CPAP, BiPAP, PEEP to increase that oxygen delivery. And in this case, if we had a diver that we were having difficulty oxygenating, it's something that we could consider, but it's a delicate mix there again, because if the diver also experienced any combined pulmonary overpressurization, then if we put them on CPAP, we can make that worse. If they had any breath hold during their ascent and popped any portions of the lung tissue, then delivering that gas at pressure could make things worse. But divers generally compensate well. They generally oxygenate well. So that's usually not the issue. The issue is we need to get them to a chamber.
Awesome. Well, that's a really good overview. So we kind of talked about the physiology of the Henry's law, and then when it kind of goes wrong, and then an extreme case when we got bubbles blocking stuff. So like you said, the Henry's law is super closely related. In fact, that's kind of why it turns into an issue, is that once the pressure above that fluid gets really low, gas tends to expand in size, and which is why we get those larger bubbles in the first place. And that's Boyle's law. So Boyle's law is the relationship between pressure and volume, which is, I guess maybe the simplest way to think about it is if you let a helium balloon go, floats up and up and up and up and up, and as the pressure exerted on that gas decreases on the outside, it starts to expand, and eventually it pops, right? So there's a problem with that when it comes to our bodies. So I'll tell you what happened to me. So we just went to the initial assessment conference in New York, and before we went, I had a sinus infection that like really sucked. And even at sea level, I had all of this sinus pressure in like my maxillary sinuses and stuff, and my frontal sinuses, and especially like right up here below my right eye. And it was just bad at sea level. And it was so bad that my teeth in the front were all numb. It felt like I was at the dentist. And so I was really, really nervous about flying. And so I'm trying to look up all these, what should you do? I think the reason I actually think it happened is I took too many decongestants while I had the sinus infection. I think I dried out my sinuses and caused a blockage, which my wife gave me a good I told you so about the decongestants. And so it turned out to be bad. And so this gas is trapped in there, right? So I have like a fixed container inside my face, and I'm about to take a plane ride where we're going to go up to 30-some thousand, whatever feet. And of course, now Boyle's law tells us that the pressure that's being exerted on that volume of gas is now going to decrease, even though I'm in a pressurized cabin. I mean, everybody knows you can hear your ears popping, air leaving your eustachian tubes. You kind of like, I guess, I don't know if the term is off gas, but you off pressure, release that pressure from wherever it can go. And I couldn't. And so because I was hoping once we got up to altitude that this pressure in my sinus was just going to leak out. I was thinking maybe it'll like find a little pressure relief valve and it'll squeak out. You know how like sometimes you're really congested and then you get the squeak that comes out and you're like, oh man, I feel so much better. It never happened. And so luckily I premedicated myself before this trip, because if I wouldn't have, I think I would have like had a full blown panic, because the pain in my face was so bad. And I can hear the joke coming, man, you think your face hurts, man, it's killing me. But it was real. I beat you to it, Mike. But it was so bad. And so, if you think about something really simple like that, and there's names for all those ones. So that one's called, like, people call it sinus squeeze or barosinusitis or whatever. And so they got sinus squeeze. You can have it in your ears. You can have it in your tooth. And so those are really simple ones, which can cause pain. And yeah, you could cause, if that volume gets big enough, maybe you could rupture an eardrum. I'm sure that's happened to people. Or you could rupture a sinus, or, I'm sure the tooth pain that I wouldn't have even gone if it was my tooth, because I have a thing with teeth, but I'm sure that that's excruciating. But there are other issues that can happen. If you think about essentially any gas that you wouldn't want to expand when you get to altitude, that's a real consideration. So I was, I put in the blog the difference between a gas under pressure pretty much at sea level and then at like 1,500 feet. And I referenced a paper in there where I was calculating how much like a pneumothorax would expand, and it was about 10%. It could increase size about 10%. So I was like, man, that's a real flight consideration that you should really think about that, especially if it's getting actively worse and then you fly somebody too, or if you go into like a fixed wing or something like that, could be a huge issue if that's just 1,500 feet.
Oh yeah, for sure. Well, and obviously anything that's filled with gas is, and has something containing it, is going to be similar to what you're experiencing in your sinus and inner ear, in the inability to equalize that to the environment. Think about anything with a cuff, or any place else that we might have. That we might have trapped gas, like a pneumomediastinum or something like that, or you have those chronic emphysema COPD patients that maybe rupture a bleb, and now you've got gas that's contained within the chest cavity that is going to expand, just based on Boyle's law. You were like the exception, because that's just straight up Boyle's that's at work there. Boils, and what you also discovered some rebound constriction from overuse of decongestants, which that's a real thing. Use too many of those, especially anything inhaled, and you can get some pretty serious rebound constriction. So it actually makes it's counterintuitive, but it makes it worse, which is probably what you experienced. It's a good thing you didn't have to go to the bathroom. What do you think would happen then?
There's oh man, I put it in the blog. I'm actually gonna hang on, I got it in front of me. I got to tell you what it's called. HAFE. I don't know what you'd call it. HAFE, high altitude flatus expulsion. Hopefully expulsion, and not only expansion. So if you do have air in your guts, which the air on a plane is recycled, and so everybody's farting, man, and it's just Boyle's law, man. You're inhaling everybody's farts.
Yeah, constantly. People have been worried about what they're going to do for COVID. Well, we've been breathing in people's poop for how long now?
Forever. Pretty much forever.
Boyle's law. It's been as long as there's been planes.
Yeah.
So the Wright brothers were they were breathing.
At least they had open tops.
Right. Helps them out.
So that's one thing. Just any of these air pockets can expand. Whether you have a pneumothorax, you mentioned a mediastinum. But then, there is an equipment aspect to it as well, where, if you have a cuff, and you want to watch out for that, because if you overpressurize an endotracheal tube cuff, I mean, that can have, it's just like it's like a bed sore, it's above the inside of your trachea. That can cause later on tracheal stenosis or tracheal malacia, where then they have like a really weak trachea. So you have to be careful for that. And so if you take the volume out, like let's say it gets really overpressurized at altitude, and then you take it out, well, then there's less volume of that gas. And so when you return back down, now you're going to have a low cuff pressure. And so I don't think that there's anything that I guess you can use fluid instead. You can put saline in there, or sterile, whatever you want. So you can put saline in that kind of stuff, whether SGA or an endotracheal tube. There's not much you can do for like a vacuum splint. You're just going to have to deal with it. But I guess one thing you can do for IV bags is you can take the fluid, or you can take the air out of IV bags and spike them like you would an art line where you got no air in there. That might save you some trouble later on, because especially if you're running something by gravity, when that air expands, it's essentially like putting that thing in a pressure bag. And then your fluid infusion rate might go up like crazy. So
right.
Hopefully it doesn't too much. Like, hopefully the bag's not tight to begin with, obviously. But I would say you'd limit the amount of errors that you run into if you just got rid of that air altogether. I hate having air in my bags anyway, because without a doubt, somebody who flips them upside down or something, and I hate air alarms. So I think that's good practice anyway. But you got to be really careful for that, because it can change your infusion rate.
Oh yeah. Well, the same sort of reason that, if you're transducing art lines, you're going to re-zero at cruise altitude, and then again, when landing, because the atmospheric pressure has changed. So.
Yeah. That's another great point. Yeah. So everything is going to change. Everything that's pressure related, anything that has any gas in it at all is going to have to get recalibrated and then calibrated again. So in the blog, I mentioned like ideal gas law, and then I mentioned a couple that talk about temperature as well. And then we ended with Avogadro's law. And those, didn't have as much clinical.
I love guacamole.
Yeah. So those didn't have very much clinical significance to them. I mean, it's really good to understand the ideal gas law. And then you want to understand like how temperatures affect this stuff as well. There's a little bit of like interesting physiology you can get into with Charles and Gay-Lussac's law, but then Avogadro's law is kind of pure book knowledge, at least as far as we go. And maybe somebody can prove me wrong. Let me know in the comments if I'm completely missing the base on something with that gas law, because I might be. But did we miss any clinical points because these were the two big ones? Definitely the Boyle's and the Henry's law. Did we miss any big clinical points that you can think of?
No, and you're exactly right. Those are the two that really have the big clinical implications for every type of patient, because it doesn't matter. We're always trying to move gases around. And one thing that I did want to quickly point out, because you had mentioned like endotracheal tube cuffs and changing that gas volume. These are things that I discovered about a year or so ago when we started carrying manometers to measure cuff pressures. We are so overinflating these things. Now we measure a cuff pressure for every advanced airway that we take over in the flight service that I work for. I've yet to find one that wasn't almost double the acceptable pressure. So 30 centimeters of water, oftentimes double or more of that. And can really do some pretty significant damage. So we want to be careful when we're inflating those endotracheal tube cuffs and anything that's in an airway that has a cuff, and probably something good to press your services to start carrying the syringes that measure it, because they're not that expensive. They're reusable.
I was just going to say, so do you guys have, what is that called? A cuff fill?
Cuff fill. Yeah.
Cuff fill. Those are the ones with
they're simple.
Yeah, the little digital thing on there. Yeah. The cuffulators, and I think I believe I'm right in the name, but there's like those ones that look like a blood pressure cuff.
Yeah.
Those are really expensive.
Yeah, and I don't know if I'm so much a fan of those. I messed with them in simulation lab, but not on actual patients. But I've used the cuff fill obviously several times, and it's so nice because not only are you measuring the pressure, but you can adjust it at the same time. Mm-hmm. And then we also want to, I don't want to get too far off on a tangent here, but it should definitely be paired with subglottic suctioning, because anytime we relieve that pressure on that cuff, it's going to be holding something back. So there's usually secretions that come back up. So we want to be prepared to suction those out. Just something to think about.
You measuring that cuff pressure at any time during, is it inhalation, exhalation? Does it matter? You average it out?
I haven't really, I'm not sure. That's a good question. I'll have to, next time I measure one, I'll measure both sides and see.
I think as long as you're underneath that pressure, I think you're going to be okay. And knowing is better than not knowing too, because if you're not checking it, it might be a long time before somebody else checks it, because we know how that goes with a lot of different items. If you don't check it,
for sure,
assuming that the next person is going to get around to realizing that it's 2 to 3 times its pressure, I wouldn't put any money on that at all.
Yeah. And it's not just, I'm not just dogging on pre-hospital. I mean, this is interfacility stuff too.
Oh yeah.
Like taking it from other facilities, and we're consistently finding overinflated cuffs. So it's just something to think about. Something to throw in there. This podcast was not sponsored by Cuff Fill. But,
unless they want to. Unless they call me before tomorrow morning, we'll let them. But, awesome, man. Well, thanks so much for coming on and talking about your experience getting bent. And that was good, man. These are definitely gas laws where you can draw a lot of clinical knowledge from. My other ones that I'm gonna do in the follow-up blog for this one is gonna be Dalton and Amagat, and then Graham and Fick. So I'm going to see how much clinical application I can draw to those. I think Graham and Fick, we'll see. We're going to see about those. I might have you back on to see what you got to say about these. But I really appreciate it, man. Thanks for hopping on with me.
Yeah, thanks for having me, Sam. I appreciate it.